Hello and welcome to this GP Notebook podcast where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson. I'm a GP in South West Scotland and I also co-host the GP Notebook study groups. Now you can find us on all major podcast platforms including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes. And if you like what you hear, please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook or visit gpnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now in this episode, I'm going to be discussing ganglions, having recently been reminded of this problem in seeing 3 patients with them in 3 consecutive surgeries. Now, ganglions are the most common type of tumour located within the hand and wrist and account for around 50 to 70% of soft tissue tumours found there. They're more likely to be found in women with a female to male ratio of 3 to 1, and they have a peak incidence between the ages of about 20 to 40, with a much lower incidence in children and the elderly. Now these cysts most frequently occur on the dorsal aspect of the wrist, up to 70%, followed by the volar wrist, and less commonly foot, knee and shoulder. Now, interestingly, there's no specific identifiable causative factor that we know of for the development of a ganglion, although we do have multiple hypotheses. And although a definitive link between the development of a ganglion and traumatic injury has not been established, traumatic events may be recalled and linked to a ganglion by up to 40% of patients. Other theories here include repetitive microtrauma that allows synovial fluid to accumulate outside the joint capsule but prevent its return, mucinous degeneration of connective tissue that results in myxoid changes and fluid accumulation, and chronic inflammation for whatever cause, leading to increased hyaluronic acid and glycosaminoglycan production, which then contributes to cyst formation. Histologically, ganglions lack a true epithelial lining and are composed of a dense, fibrous connective tissue wall with variable myxoid degeneration, and the fluid inside a ganglion is thick and gelatinous due to its high concentration of hyaluronic acid, albumin, globulin and glucosamine. Now, as you know, patients often present to us with a ganglion because of cosmetic concerns, and these cysts may develop within a few days only or over a long period of time, and are typically asymptomatic, but patients may report localized swelling, pain and tenderness, reduced motion, and even neurological symptoms. So we see a palpable, firm, fluctuant mass, which is often mobile, and it transilluminates typically with a reddish glow. About a third of patients report dull pain, which is exacerbated by activity, and there may be a decreased range of motion due to either mechanical obstruction or compression. With volar wrist ganglion, these can cause compression of the median or ulnar nerve and can lead to paresthesia or weakness. Now, I mentioned transillumination there, and this test is a hallmark of ganglion cysts, and it's positive when light shone from a pen light passes through the cyst, and this differentiates it from solid tumours. Occasionally, you may see Tinel's sign being present, and this suggests local nerve involvement. Now, in my experience, laboratory tests are usually entirely normal and are only required if you've got any suspicions that infection might be present. And by the same token, radiography doesn't usually yield information that alters the care plans of our patients with ganglion, and so imaging is not typically indicated unless you've got any doubt about the cause of the mass. Now, if you're going to go imaging, then ultrasound can help differentiate solid from cystic lesions, and MRI scans are the gold standard for evaluating deep-seated or occult ganglia, particularly intraosseous cysts. Also, on rare occasions, X-rays may be useful in ruling out osseous pathology, and I'm thinking of things like arthritis or bone tumours here. But there's no difference in the ganglion detection rate between ultrasound and MRI. Now, dorsal ganglia may be aspirated for diagnostic as well as potentially curative purposes, but aspiration of any volar ganglia are not recommended due to the potential risk of injury to the radial artery. And it goes without saying that great care must always be taken with any aspiration here, because the ganglion is in direct communication with the wrist joint. And although this is a rare complication, septic arthritis is a potential complication. So, any aspiration technique must always include ultra-sterile preparation, the introduction of a large bore needle, such as an 18 gauge, into the cyst, and then removal of the cyst contents. And if you see a clear, jelly-like viscous mucin, this is diagnostic of a ganglion cyst. Now, given their varied presentation, ganglions must be distinguished from other things such as lipomas, giant cell tumours, synovial sarcomas, or even carpal bossing. Now, lipomas are soft, they do not transilluminate, and they are typically not painful. They're usually not entirely spherical, aspiration does not yield any fluid, and ultrasound shows a non-cystic mass with an MRI demonstrating a well-circumscribed mass. Giant cell tumours of a tendon sheath, on the other hand, are firm, slow-growing, and again do not transilluminate. The mass is fixed to the underlying tendon sheath, and so it's much less mobile than a ganglion cyst. Again, aspiration does not yield any fluid, and MRI or ultrasound confirms a solid tumour located adjacent to the tendon sheath. Synovial sarcomas are rare but malignant lumps that always require biopsy. They're typically not well circumscribed, nor as freely mobile as a ganglion, but they can be difficult to distinguish given the varied presentation of sarcomas. And finally, carpal bossing, if present, is usually easy to differentiate, as this is a simple bony protuberance at the carpometacarpal joint. Now, if we're looking at management, most of us would go for conservative treatment first. And this is the right thing to do, because this type of treatment results in spontaneous resolution in over half of adults and 9 out of 10 children over a 9 to 12 month period. And given that ganglia are the most common benign tumours of the hand and wrist, with no reported cases of malignancy linked to them, this line of treatment, including activity modification to avoid painful wrist positions, may be all that's needed. You might consider compressive wraps or wrist supports worn during activities that worsen any discomfort, as this can help in some cases. If we're looking at aspiration, then cyst puncture and drainage, with or without corticosteroid injections, is the primary form of the closed management of dorsal ganglia and can be curative as well as diagnostic. But I will say once again here, do not aspirate a volar ganglion due to the potential risk of injury to the radial artery. Aspiration of dorsal ganglion have been found to have a 13% success rate with a single puncture and drainage, and this increases to approximately 40% if the wrist is then splinted for about 3 weeks afterwards. This even goes up to 85% if there are 3 treatments here. And a question that's often asked as to whether steroids should be injected at the same time, but the evidence suggests that simple aspiration yields similar success rates to aspiration and injection of a corticosteroid. However, about 6 out of 10 patients who do undergo aspiration will experience a recurrence of their ganglion at some time. Now, I mentioned splinting of the wrist to help reduce irritation in some patients. Overall, this action probably has limited efficacy in any resolution of a ganglion. Occasionally, we may want to consider surgical management, and indications for surgical excision here include pain that's refractory to conservative treatment, if there's any neurovascular compromise, and if there's functional impairment or recurrence following an aspiration. Now, although surgery is the most successful treatment with ganglions, it is not a guaranteed cure, but surgical options here include formal open excision and arthroscopic decompression and resection. So open excision fundamentally involves removal of the cyst along with any stalk and a slight portion of the joint capsule, whereas arthroscopic excision is minimally invasive and with a slightly lower recurrence rate. So we've got recurrence rates of about 8% for arthroscopic surgery and about 10% for open surgery. Therapies such as sclerotherapy and laser therapy are emerging, but these are both under investigation for reducing recurrence rates. So the jury is slightly out compared to open excision and arthroscopic excision. Now, I'm sure that, like me, you'll have all had patients that talk in your surgeries about hitting a ganglion to try and make it go away. And in fact, the Victorians used to do this with the family Bible. But, as you might imagine, such a technique is most definitely not to be recommended and may in fact lead to problems such as fracturing of the distal radius or significant injury to the surrounding structures. So that's a quick overview of ganglions, and I hope you found this podcast helpful the next time a patient sits in front of you and shows you theirs. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following us at the podcast and leaving a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round on a huge range of topics, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, thank you so much for listening, and until the next time, goodbye.